Hello, and welcome to our Community Conversations series with Safe Harbor of Sheboygan County. My name is Patrick, and my role with Safe Harbor is in prevention education. Our goals with this series are focused on creating a greater understanding about community agencies that victim survivors of sexual assault may first report to, along with gaining clarity regarding the roles of those agencies, the mechanisms of their support, and the resources available through those agencies. This series is also focused on creating more awareness surrounding the options available to victims and survivors so they are able to make a more informed decision about how they wish to navigate community resources. Today I'm joined by Dina, a sexual assault nursing exam SANE coordinator with Aurora. Dina, welcome. And could you begin by introducing yourself and speaking to your role and responsibilities as a SANE coordinator with Aurora?
Certainly. Hello, Patrick. My name is Dina Grundle. I'm the forensic nursing coordinator at Aurora Healthcare in Sheboygan. I've been doing this for about 13 years. Really, my role is really ensuring that we are offering services to victims of violence 24/7 through our emergency department. So I coordinate that to ensure that that occurs, that we always have a nurse available to our patients when they need us, not when it's just important that we're available to them when they need our assistance.
Perfect, thank you. And would you then maybe speak to more about what a sexual assault nursing exam, or often we say SANE, is and what that process looks like?
Certainly. So what we call a SANE exam is really an offer of services when someone has gone through a sexual assault. It could be a short, quick exam, really depending on what that patient wants, but it entails lots of different options. Sometimes there's some time frames that we are limited to, and I'll give some examples of that. But really, we want to see victims of violence, sexual assault victims, even if their assault is 6 months ago. We can connect them with services throughout our community. Many times we have patients who aren't sure, did they contract an STD during this? Is their body safe and well? Sometimes people don't know that even 6 months later. So that's really important, that timeframes don't really limit our patients feeling like when they can come. We're also available 24/7. So when a patient wants to come at 1 o'clock in the morning, even if their assault was 6 months ago, this is the time that they're ready, and that's okay. Mm-hmm. We've had it where patients who have opted to schedule appointments, which people find a little weird. Like, why would someone schedule an appointment for a sexual assault? But sometimes that's what's best for them. It's also waiting for you. Sometimes we have patients present to the ER. There is a little wait time of about 30 minutes while they're waiting for the nurse to come and see them. So sometimes that's a better option. Being able to coordinate their care in a more scheduled thing is sometimes better for our patients. But some of the services we offer is STD meds, so sexually transmitted disease or infection meds, to cover gonorrhea, chlamydia, trich, HIV if we're within 3 days of the assault. So that time frame is really specific to 72 hours. However, if we're past that, we can certainly offer testing. We can offer syphilis testing. We can talk about hepatitis B. Is there a concern about those things? We see human trafficking victims where their assaults are over months and years. So offering all those services are really important in connecting them to other physicians or providers to provide care long-term if that's a need. We offer pregnancy testing, medication to prevent pregnancy. That's a 5-day period that we offer for free. There's no cost to that. An exam. And patients get to determine what type of exam. They get to determine no exam, which means that I really would only assess parts of their bodies that I see. That's okay. It could be a genital exam. It could be a pelvic exam, which could include a speculum or without, and patients get to choose that too. The medications, we can talk about different options on how to provide them. Those medications are also free. HIV meds are free. We ensure that that's really important because the cost of HIV meds can be an extreme barrier, especially with patients who have insurance. It could be that the patients just tell us what happened to them and how do we manage that? So that's really important. So it can look, if they have physical injuries that we can see, does that patient want those photos taken? We can take photos, we store them in a completely separate system, so those would never end up in their medical chart. I know patients sometimes worry, where do those photos end up? That is kept very, very private in a specific system, only available to a very few people. We offer them options of who do they want to talk to. We connect them with resources like Safe Harbor, adult resource services, law enforcement, if that's a pursuit in which they want to pursue at this time. We can do evidence collection with or without law enforcement involvement, which is really great in our state. It gives us an option to collect evidence if they're not ready to do that, and they'll hold that for a minimum of 10 years. So for each patient, the services that they receive can look very different from one to another because it's very individual based on what that patient needs and wants in that time. The patient could say, you know what, I don't want to, I've changed my mind, I don't even want to be here, I have to go. They can certainly go and they can come back, and we'd never be upset about that. We offer patients, like if we start something and you decide that you don't want to, you say, I need a break or I need to be done, then we're done. And we take a pause and we give that patient a chance to either take their breath or say, you know what, if you want to go, we'll certainly get your things and ready to go. We have shower facilities, we have clothing, we have everything that that patient may need. And if we don't have it, we're certainly going to find a way to get that for them.
Perfect, thank you. When thinking about the availability or the accessibility of a sexual assault nursing exam, where in Sheboygan County is a sexual assault nursing exam available to victim survivors?
Currently, the only SANE program or forensic nursing program is at Aurora Sheboygan Memorial, but we have partnered with St. Nicholas Hospital that if a patient presents there, they'll get a medical screening to make sure that they're safe to leave that hospital, and then they direct them to come by us. And St. Nick's does a really great job of calling us, saying they have a patient, and then giving us a little bit of report to sort of connect and provide services when the time is appropriate for that patient.
Okay, perfect, thank you. So we acknowledge that we work from a place that is victim survivor centered. In many ways, this means, as you've identified, that the victim survivor makes decisions that are best for them. Would you speak to the available options surrounding a sexual assault nursing exam?
So do you mean like cost?
So I think like during the exam itself, and I think you had kind of spoke a little bit to some of those elements, but I think even just kind of identifying maybe a little bit more specifically like what some of those options might entail.
Okay, so if you were my patient, Patrick, the things that I would offer to you is I would say, you know, based on the history you provided, here are some things we could offer. Medications to help prevent STDs. So one of those medications currently is Zithromax to help prevent chlamydia. We offer Rocephin to help prevent gonorrhea. HIV meds, of course, to help prevent HIV. Emergency contraception to prevent a pregnancy. And we offer that to all male and female, not assuming that their biological body is the same as what they identify with. So we ensure that we offer that to every person that comes through our doors, so we don't make a mistake and miss somebody that might be important to.
Sure.
Evidence collection, depending on, so typically 72 hours is the best time to get evidence off of somebody's body. However, in our state, we offer it up to 120 hours. Just in case, you know, if there is any showering or anything like that, it's more likely we need the 72 hours or less, but we don't close that window for them. We stay it open for 120 because we can't see DNA, so we give them those options about how we manage that. And then evidence collection, the options are, do you want to report to police now, or would you rather think about that, wait? If a patient says, I'd rather wait, then we would collect that evidence. It gets packaged up like any other kit would be, and it gets mailed directly to the Wisconsin Crime Lab in Madison, and it gets held there. And that stays private. That patient, nobody from the crime lab or law enforcement is going to reach out to them and say, hey, we have your name here. That is completely confidential, and they're going to keep it that way. The only group that we can't promise that confidentiality is people under the age of 18. So Patrick, if you came to me and you were 17, I would tell you, Patrick, everything you tell me, I have to inform law enforcement about what occurred. However, we can still offer you all of the things that I listed, even though you don't necessarily tell me what happened, because you want to keep that to yourself now.
Sure.
And that's okay. So it's really important that us as nurses really inform our patients about what could happen if you tell me something. And then we ensure that our patients also know that the one who can be confidential and can keep that information and walk them through the next steps is Safe Harbor or other advocacy agencies. They are confidential, whereas we aren't always. So I say to my patient, even adults, if there's something you don't want law enforcement to know or me to know, that's okay. Just don't tell me. But everything that you do tell me could potentially be used in a court of law. So if you want to keep that private, that's okay. And we want to make sure that our patients feel safe and can trust us when they leave. So we really want to be open and honest about everything we know while it's happening in that room with our patients.
Perfect. Thank you. What recommendations might you have regarding a sexual assault nursing exam?
Well, typically I don't necessarily give my patients recommendations, except that when that patient leaves, that they feel healthier and hopefully a little safer than they walked in our doors. So usually as a healthcare person, medications to help prevent STDs. Now, for some people, medications is not a route that they prefer to go. Then we talk about testing. How do we prevent, further issues with that person with certain infections? So we talk about risk and benefits. If that patient opts to not take those medications, what do they need to do to make sure that they're safe and healthy? So that's where we would recommend, if you don't take these medications, we really recommend that you have follow-up with someone you trust in about 2 weeks to ensure that you get testing. And then if any of those things become a positive, where you would be positive of one of those illnesses or infections, then that specific medication for that illness can be treated at that time. Initially, when we see patients, we might just give them sort of all these medications, sort of just cover it, just in case. But for some people, they're not comfortable doing that, and that's okay too. It could be also about, the one thing I really try to do is connect them with advocacy. That I think is really, if I was gonna say I recommend anything, I would say that's my recommendation, because I can't walk that path with those patients. However, advocacy can. And whatever that path looks like can be individual between Safe Harbor and that patient or victim. And that's great. I can't do that. The patients I've seen who didn't work with advocacy years ago, when we weren't great at connecting with Safe Harbor, we saw really bad outcomes with their mental health, and some other things that really, I think if they would have been connected with Safe Harbor, I think would have had a very different outcome, or maybe a way less bumpy path. So that would be my recommendation, is that we connect with advocacy and that a patient, feels safer and healthier when they walk out the door.
Yeah, thank you. I appreciate that perspective. And I think, speaking to the years of experience with respects to kind of identifying and seeing the difference with respects to clients or patients who have worked with advocacy or maybe not worked with advocacy, and really kind of seeing the difference that advocacy has. So thank you for that, Dina. I appreciate the context. I'm sorry, once the exam is then complete, what are next steps? More specifically, is there a cost associated with the exam? I know you've mentioned free, multiple times. How does that work, and how do those services remain to be at no cost to the victim survivor?
So it gets a little complicated depending on the circumstances. But if us as the nurse is the only one who's really involved in their care and a physician isn't seeing them for any sort of physical injury, then our services are free. And how the hospital's able to do that is a couple of things. So patients also get to decide, if they have insurance, whether or not we bill that insurance. So Patrick, if it were you and you had insurance and you said, you know what, I'm still connected to the person who harmed me, and through that insurance, I do not want that billed. It could be you're a college student and don't want your parents to know that you're in our department. We wouldn't bill your insurance. That's a private matter between you and your family. You get to decide when they know, if they ever know. So us billing insurance would really put our patients in a really kind of bind or issue, and pushing them into a circumstance they weren't necessarily ready to be in. So we recognize that that's also a choice of picking whether or not we bill insurance. If they have no insurance, or they opt not to allow us to bill insurance, then we go through what we call as a SAFE fund. It's a sexual assault fund that's built up through our state that ensures the hospital gets some reimbursement to help cover really some of the on-call costs and educational costs, and maybe some of the medications. Usually the hospital really sort of writes off a lot of that. Emergency contraception is something that the SAFE fund does not cover, but our hospital doesn't bill for. That is something the hospital always gives away, because that's the right thing to do. HIV meds, those can go as high as about $3,600 a month is the last number I sort of paid attention to. That is really costly. People with insurance that use insurance, for myself, that copay, I think if I did the math, is at least $500. That's a lot of money for anyone to incur on 30 days worth of medications. So the hospital has now implemented a program that says those are free too. So there will be, and patients can also decide whether or not we bill their insurance. So if you said, no, we can't bill your insurance, and you were opting to take those medications, the hospital would pay the entire cost of that and get you all those medications for free. Now, let's say you have a physical injury that we're concerned about. Sometimes we see patients who have a strangulation, and that is something that we need our providers or our physicians to see that patient. That does incur a cost. However, there are certain things that we can do. If you are working with law enforcement, crime victims compensation is something that can help with those costs. The issue with crime victims compensation, however, is it has to be the last payer of resort, which means that I'm required to put that through your insurance, because now we've developed an emergency room bill that now needs to be managed. However, our hospital's been really great when we've had these concerns of someone who's a victim of violence, and how do we support them so that they don't receive a bill when it's really, no one should have to pay for their care when someone else hurts them. That's not the right thing to do. So we take that to the committee within our hospital. And thus far, every time I've gone to that committee, they have removed the bill and ensured that that patient got free care, which has been really great. I've had a really great experience with Aurora's system in ensuring that victims of violence don't feel like another victim or have more hurdles when they find out they have this large bill they have to manage. We work with other departments and things to figure it out. Sometimes it does, sometimes will take me a little while, usually about 1 to 3 months while I work with the billing in our internal hospital. But in that moment, we do have the bill held. So the patient won't get a bill. They shouldn't be getting, anything from collections saying, how come this is happening? It just really stops while I work through our system to get that taken care of.
Yeah, thank you. I think that that's a really great component for our community to have an understanding of in terms of those costs that may exist, but then how do we as a community really kind of, I think, take care of those costs, as you said, so that way victims, survivors don't feel re-victimized, through a system, through another agency, right? So thank you for giving that greater understanding. So the final question that I have for you today, my apologies. So in thinking about marginalized populations and knowing that there are likely, that marginalized populations are likely to have a higher victimization rate along with a lower reporting rate, how does a nurse conducting a sexual assault nursing exam best approach working with victim survivors of marginalized populations who may not be as trusting of systems and agencies?
So I think it's about being, first off, being really honest with our patients. So when we meet a patient, that everything that we tell them is factual and truthful. That we're giving our patients choices, real choices. So when I come to my patient and I say, here's all the things we can offer, these are a choice, I'm truly asking. I'm pausing, giving that patient enough time to actually make a decision. I'm not saying, I don't walk into the room like I typically would an emergency room patient, maybe who's there for chest pain, and says, we need to do these things. I'm not going to say that to these patients. I'm not going to say we need to do this, because we don't need to do any of it. What we need to do is let that patient make a choice. So when we get to those choices, for example, if that patient says, yes, I want all those things, when we get to those things, if it's when we get to the medications, I say, here's the medications, do you still want to take them? And do you have any questions about that? It's also talking about what's the risk if I take the medications? What is the benefit if I take these medications? It's also a really good idea that I look through his or her history. Do I understand, medically about this patient? There are some patients that it's not a good idea to add medications to maybe what other medications they have. So if I walk into a patient's room and have really no information about them at all, that's also an error and an area where that may seem untrustworthy. Like, really, a nurse just walked in the room, doesn't know anything about me. So it's that too. I think the more and more that we allow patients to make choices, that they start to feel trust. When we bring in other services to provide them with the next steps, I think that builds trust. When I say to a patient, you don't have to talk to law enforcement if you don't want to, and we keep to that promise, that's another piece of trust. And the biggest one, I think, is we don't make promises we can't keep. So if my nurses or myself make a promise, you have to keep it. If a patient says, you know what, I'm not ready to do this now, we say, if you ever feel like you need to come somewhere safe, please come back. We will do everything we can to help you. And that's the truth. We really will. I can't promise someone safety, but I can promise I will try. So I think as we do that, I think overall, I think the more times we have these conversations, not just about sexual assault nursing, but nursing in general, that every connection that that patient has with healthcare after that, if we really do that, give patients choice, the more and more trust they have in us to say, you know what, I had a really good experience at that site, I'm going to go back there. And we need to continue with that, not just in our department, but every department. It really is just a team effort. And it also is about when they go to Safe Harbor, when I say, hey, when you meet with Safe Harbor, these are the things that they can offer. This is what they will do. And I know that Safe Harbor will come through because I've trusted them. I've worked with them. If I say, you know what, if you work with Sheboygan Police Department, I know that you will have this experience because I've worked with them so many times before and I've had good experiences with them. Same thing with Sheboygan Sheriff's Department. Super great experiences with them. I could say, you can meet with the Sheriff's Department. Here's what could happen. And I have confidence in our law enforcement within our county, and they will see that. They will see that we have good processes in place to sort of build on that. And then when we make mistakes, we're going to learn from them. We're going to follow up with our patients or our victim survivors to say, here's what we learned. We give them 24-hour phone calls or numbers that said, you can call me anytime. If there's any concerns, please tell me. And then together as agencies, we work together so often that we say, if there's an issue with one of us, we need to know about it now. And we're so great about doing that. If there's an issue or a concern or a worry about something, or maybe not even that, like, hey, we have this with this patient, how can we come together and surround that patient? We do that. And I think the more we do that, patients will see that they can trust us.
Yeah, thank you. Thank you for that perspective. I think that's a really valuable insight for our community to have. The final question then that I have for you today is in recognizing victims and survivors of sexual assault have experienced a high degree of trauma. What does trauma-informed care or trauma-informed approach mean to you in your work?
So trauma-informed care is really about sort of a mind process and thoughts and things that we sort of do before and after we see patients. So it could be as simple as we look at paperwork to ensure that, you know, is this the least amount of paperwork that that patient has to go through when they're with us? It could be as simple as, to be quite honest with you, whether or not we have a mirror in the bathroom. So when someone goes to wash their hands, are they ready to look at what they look like in that moment? And for me, I might look at a patient and think they look fine, but they may be up for 24 hours, so they might look really tired. For them to look at themselves, that might be very traumatizing. So just as simple as giving them options to say, would you like a mirror? So they can choose to look at whatever they want. But it's really about ensuring a mindset of understanding that trauma impacts people very individual and very uniquely for that person. And that you don't have an expectation of how that patient's going to respond and act when we walk in the room. That in the moment, we are going to work with that patient about how they're responding to their trauma and provide them support. I think that's the biggest things. And that we're going to continue to work on that each and every day to provide services in a trauma-informed way, which means we think about what we're going to do next to best ensure the best care for that patient, and not make them feel like at any point during their visit that what had happened to them was their fault. So that's, I think, really the basis of what we have.
Wonderful. Thank you, Dina. And thank you for having this conversation with me today. And thank you to our audience as well. Please join us in future conversations as we continue our Sexual Assault Awareness Month Community Conversation series. Thank you.